So my name is Ann Spadard, and I am very happy to be here today to talk about the Home Health Quality Reporting Program, and this is the provider training. And we're going to be talking about the changes in skin integrity, the post-acute care pressure ulcer injury measure M1311. All right. It's very disconcerting to see myself up there. So we're going to start today going through, like we will with all the presentations, the acronyms. So you have them here listed, and you can use those as a reference. And my section actually has quite a few acronyms in it. So we will go through each one of those. And I think there's a summary document in your resource documents that has all of the acronyms in it, so you might want to just pull that out to the left. The other thing, if you'll go to your folders, and for those of you who are looking at this live streaming, in the resource material for day one, there is a packet of information. It says day one scenarios, and it starts with section J. So if you can pull that out, that would be helpful. And we're going to be the third page in. We don't need it right away, but if you just pull it out, when we start talking about the practice scenarios, you'll be able to go ahead, look at the scenario, and start coding it. As you'll see, I have coded my own just to have it here. So just if you pull that out, that would be great. All righty. So today we're going to, the learning objectives are, we're going to describe the modified cross-setting pressure ulcer / injury quality measure. You'll be able to articulate the rationale for the changes of M1311 and any implications for coding. And we're going to apply the coding instructions to accurately code practice scenarios. And this section actually will go through some base material, and there's a lot of practice opportunities. And the nice thing about the practice opportunities, you can take those back as education materials for your staff, and you can use them. So what's posted online, again, remember, it does not have the answers on it, but after we finish the couple days of training, the materials will be reposted with the answers, so you'll have them just to make sure when you go ahead and use them for education of your staff. So changes in skin integrity, the pressure ulcer injury measure. This quality measure reports the % of quality episodes with reports of stage 2 through 4 pressure ulcers or unstageable pressure ulcers or injuries due to slough or eschar, non-removable dressings or devices, or deep tissue injury that were not present or were at a lesser stage on admission. So this is a critical definition that you need to have and keep it in the forefront of your mind. So this is the definition within the quality measure. So the description of this measure, its quality episodes are defined by pairing the start of care or the resumption of care, the SOC-ROC, assessment with an assessment completed at discharge. So you need to have both pieces to be included in for this measure. And the measure is calculated using data from the Outcomes and Assessment Information Set, or of course the OASIS. This particular measure replaces the current pressure ulcer measure, which was % of residents or patients with pressure ulcers that are new or worsened, short stay, and that comes out of actually the MDS terminology for NQF measure 0678. And it's the cross-setting quality measure implemented to meet the requirements of the Improving Medicare Post-Acute Care Transformation or IMPACT Act. So as you notice, as we've been going along with all of these trainings over the last couple of years, is we're adding more measures that are now aligning. It's taken some time to align these measures across all the post-acute settings. And then we have those, so we're looking at apples to apples, unlike the jackpot fruit that Kathy was talking about this morning. All right, so the rationale for this is modified versions included new or worsened unstageable pressure ulcers or injuries, including deep tissue injuries in the measure numerator. And we're going to go through the numerator and denominator shortly. And the measure calculation has been amended to include M1311 items instead of M1313 items to reduce redundancies. And the revisions these revisions are informed by the National Pressure Ulcer Advisory Panel guidelines. So you'll see some alignment with some of the language. This quality measure will be uniformly adopted across the post-acute care continuum. So in long-term care hospitals, or LTACs, it started July 1st, 2018. Skilled nursing facilities started October 1st, 2018. Inpatient rehab facilities started the same time, October 1st, 2018. And of course, for you in the home health agencies, this will start on January 1st, 2019. So that's coming up. So to take this opportunity to learn today and then bring this back to your organizations. So it's important to always understand what is included on a measure. So what's my numerator and what are my denominators? So the numerator is the number of completed quality episodes. Remember, those are the start of care, resumption of care, and the discharge. For patients whose assessment at discharge indicated one or more new or worsened stage 2 through 4 unstageable pressure ulcers or injuries compared to the start or resumption of care assessment. So that defines who's in our numerator. And then our denominator is the number of quality episodes, except for those that meet the exclusion criteria. In the home health, quality episodes are defined by pairing assessments, which we already talked about, completed at the start or resumption of care with an assessment completed at discharge. So you need to have all of those together. So you have your total population who has started care, resumption of care, along with a discharge, and then that's your denominator, and then your numerator are those who have completed the episode and then have one of these criteria of a 2 to 4 or unstageable pressure ulcer or injury. So now let's take a moment and look at the exclusions. Good. Okay, sorry about that. So what are the exclusions for this measure? Well, episodes that end in a death at home or transfer to an inpatient facility are excluded from the measure, as OASIS data collection that occurs at these time points do not contain the items needed to compute the measure. So if you have that death at home or transfer, they're going to be excluded. Episodes without an assessment completed at the start or resumption of care and an assessment completed at the discharge excluded. So we can't do the measure if we don't have that pairing of assessments. And then episodes are excluded if the discharge assessment does not have usable responses for M1311, A through F. So if we have missing data. And so that's kind of standard. We've had that for a long time in a lot of our measures. If we have missing data, we certainly can't calculate it. So what are the measurement time windows? So the measure will be calculated quarterly using a rolling 12 months of data. For public reporting, the quality measure score reported for each quarter is calculated using a rolling 12 months of data. So as one quarter comes on, the very last quarter will fall off. And so it's a kind of a changing measure. All complete quality episodes during the 12 months, except for those that meet the exclusion criteria, are included in the denominator and are eligible for inclusion in the numerator. And again, following that same rolling 12 months. For patients with multiple episodes during the 12-month time window, each episode is eligible for inclusion in the measure. So again, remember, they need that pairing though, right? They need this start of care, resumption of care, and the discharge. But if you have a patient who may have had those pairings, maybe was off service for whatever reason, and had a break in service, now they've come back onto service, it's a new start of care, or resumption of care, and you have a discharge. So you could have a patient who could have, and had pressure ulcers, who could be counted maybe 3 times. So that's an important piece of information for you understanding how the measure is calculated. So this measure will be risk adjusted based on an evaluation of potential risk factors and their statistically significant impact on the outcome. So we know that certain things that people have or conditions or whatnot can put them at greater risk for skin breakdown. So let's look at those. So some of the risk factors are functional mobility, which is GG0170C, the mobility from lying to sitting on the side of the bed. So this is a measure that puts someone at higher risk. Bowel incontinence, so M1311, and it's bowel incontinence at least occasionally on the start of care or resumption of care. That is an area, again, if we think about it, that puts someone at greater risk for skin breakdown. If they have peripheral vascular disease, peripheral arterial disease, or diabetes, that certainly puts someone at greater risk. So now you're looking at M1311, and you'll see those disease states. And then we're looking at the low body mass index based on height and weight at the start of care or resumption of care. So those are some of the measures that Kathy talked about in her presentation. So M1060 and M1060B, so height and weight, which is going to figure out your BMI. Please note that, again, this is low body mass index. It does not go with high. So these are all risk factors that are used as part of the calculation to say, is someone kind of level sets when we're looking at people across various settings. So M1311, current number of unhealed pressure ulcers / injuries at each stage. So just make sure I did skip one. So M1311, this item identifies the number of pressure ulcers or injuries at each stage, looking at stage 2, 3, and 4, and designated as unstageable that are observed on the assessment. At discharge, this item also identifies if each pressure ulcer or injury present on discharge assessment was observed at the same stage at the time of the most recent sock rock. And we're going to go through a lot of examples. So you have 2 time points, right, that you're looking at. Start of care or resumption of care. What did we have? What was the picture of the patient or the resident there? And then we have what does the patient look like at discharge related to their pressure ulcers. Stage 1 pressure injuries and all healed pressure ulcers or injuries are not reported in this item. And I don't know that we have an example of this, but for example, if someone developed a stage, let's say stage 2 pressure ulcer during service, it wasn't there on the start or resumption of care, and then it heals before discharge, you're still going to treat it and do all of those things. We're not going to report it on here. It's not going to show up. So what are the time points? Well, I think we've talked a lot about there. Certainly start of care, resumption of care, follow-up, and then discharge from agency, not to an inpatient facility. So these are the time points that when we're completing these assessments. The items, so the summary of the changes, the item retained but different versions created for specific time points. The language was modified to align with other PAC instruments, and I'll kind of talk about where the language changed. It's highlighted in some of the slides. It was adapted for the National Pressure Ulcer Advisory Panel definitions and terminologies. And there was modified skip pattern language and direction that was put into these. So there were added text. You'll see that it used to be just pressure ulcer. Now you see pressure ulcer / injury where applicable. We added the word device to the items titled in D1, unstageable, non-removable dressing / devices, because often they're part of the, if you have it's not always a dressing, there could be a cast or other things on there that we can't remove. And then they removed suspected in evolving from the unstageable deep tissue injury. So we used to have suspected deep tissue injury, so that word suspected has been taken out. And again, this is just aligning with the National Pressure Ulcer Advisory Panel's language changes. A dash is a valid response for the discharge time point only, and CMS expects a dash Used to be a rare occasion, but there might be a situation where you have to put in a dash, and certainly is an accepted response. So the next couple of slides, we're just going to go through and show you the item sets. Now, I know this is really hard to read from the back of the room. I think in your folders there is the item sets. But we'll see where it's highlighted here. We have the current number of unhealed pressure ulcers or injuries at each stage. So that word ulcer/injury is what changed. If you go down to D1, we highlight the idea that it's dressing/devices. And then it's the number of unstageable, again, ulcers or injuries. And then for F1, we have unstageable deep tissue injury, so that word suspected, it was removed. And then the number of unstageable pressure injuries presenting as deep tissue. So, and then in the discharge version of this item set, again, you'll see ulcers/injuries highlighted here. And then here you have the skip pattern brought in. So let's just read this. It says, partial, so this is A1, stage 2, partial thickness loss of dermis presenting as a shallow open ulcer with a red-pink wound bed without slough may also present as an intact or open or ruptured blister. Number of stage 2 pressure ulcers. And once you put that in, if you put in a 0, then you go to M1311B1, stage 3. So if you have, it's a skip we used to do, so what you would see if you were doing this on a computer, you would put in 0, it would just skip you down to the next question. Because the next question asks you, of these stage 2s, now again, this is in discharge, so if you don't have any stage 2s at discharge, you then, it makes sense, right? You can't say, of these, 0, well, I don't have any, were present upon admission. And I think that's one of the confusing points that people have when they start to answer these questions. They're like, oh, but they had a stage 2 on the start of care. But when you're asking the discharge questions, you're asking about what is present upon discharge. And of those, then, if we have any, then we're going to look at how many of those were present at the start of care. So it's probably an important point when you're educating your staff. And then this just carries through, same idea here, ulcers and injuries, we added devices, and then it highlights where you can do the skip pattern. As we go through and do some of the coding scenarios, you'll see that skip pattern coming through. So know that if your answer on your discharge section of it is 0, the next question underneath it of those will also be a skip out of that. All right. So let's go through some specific coding instructions. So determining present at the most recent start of care or resumption of care. For each pressure ulcer or injury observed and coded at M13A1 through F1 on discharge, determine whether the pressure ulcer injury was observed at the same stage at the time of the most recent start of care or resumption of care. It did not form during the home health quality episode. So that's an important piece. So we have the snapshot at start of care, resumption of care, and then we have what they have at discharge. Even though they might have developed it along the way, it wasn't present upon, basically present upon admission or when you did the assessment. Let's see, okay. If the pressure ulcer injury was unstageable at the start of care or the resumption of care, but became numerically stageable later, when completing the discharge assessment, it's present at the most recent start of care or resumption of care stage should be considered the stage in which it first became numerically stageable. So what does that mean? So you're doing an assessment on a patient and you're saying it's unstageable. I don't know what the stage is, okay? Now, through debridement or whatever, let's say it's 2 weeks into your caring for this patient. Now you're saying, oh, it's very clear it's a stage 3. So now we've staged it as a stage 3. When you go to doing, now that becomes stage 3 present upon admission. You're not going to go back and change your sock rock. But now we know it's the first time it's staged as a 3. If it subsequently increases in numerical stage, we don't report it as a higher stage ulcer as being present upon the recent sock rock when completing the discharge assessment. So let's talk about this. You have a patient come in, they have an injury, let's say it's covered with slough and eschar, we can't stage it. 2 weeks in, the slough and eschar is cleaned away, debrided chemically or whatever. We now know it's a stage 3. We code it as such. At discharge, they still have that same stage 3. It's considered present upon admission. Is that clear to everyone? Okay. Same scenario. Patient comes in, covered with slough and eschar. We can't stage it. It's unstageable due to slough and eschar. 2 weeks in, it gets cleared away. The slough and the eschar, we now know it's a stage 3. So that's 2 weeks in. Let's say by 4 weeks in to your caring for that patient, it's now progressed to a stage 4. You can see bone and tendon. At the point of discharge, it is not considered present upon admission because it actually worsened in the time that you had that. Is that clear to everyone? We're going to go through some examples, and it's these subtleties that really matter. So understanding how to code these is critically important. Okay, so the general standard of practice for patients starting or resuming care is that the patient assessments are completed as close to the actual time of the start of care or resumption of care as possible. We've talked about this, anyone who's gone to these trainings or listened to them online, we've talked about that. We know that there's an assessment window that you have, right? But we're looking at the first skin assessment, the initial skin assessment. Even if the wound changes within that, your assessment time frame, once you've completed your initial skin assessment, that is your skin assessment for the looking at this particular measure. So if the pressure ulcer injury that is identified on the start of care date increases in numeric stage within the assessment time frame, the stage of the pressure ulcer or injury at the first skin assessment completed would be reported at whatever, depending on the stage, M1311, whatever letter at that start of care. So for example, a stage 2 pressure ulcer on the left heel at the start of care. 3 days later, the pressure ulcer is a stage 3. It's still within your assessment window. You report M1311, the pressure ulcer, as a stage 2, as it was per your first assessment at the start of care. So that's a subtle point, but an important point to educate your staff on. Okay. And that's consistent with all of the other care settings. That's the reason we're highlighting that. So follow-up assessments, so M1311, A1 through F1. At start of care, resumption of care, the follow-up, enter the number of ulcers for each stage that are observed at the first skin assessment, completed during the assessment time frame. And so, for example, at the start of care, in B1, enter the number of stage 3 pressure ulcers that are observed at the first skin assessment completed during the start of care assessment time frame, and enter 0 if no stage 3 pressure ulcers are observed. So here we have this start of care, resumption of care follow-up version. So again, we're going to highlight ulcers and injuries that have changed from this. We added the word device, so you'll see that there. But here's the set of questions from the item set. And you're going to see a combination of these where we'll go through the different item sets and you'll take a look at the screenshot. So for the discharge assessment, we have A1 through F1 and A2 through F2, which is of those, how many were present upon admission. So at discharge, enter the responses for each of the rows. And unless directed to skip it, so for example, if you have 0, we already talked about this, is again the discharge assessment. If I have 0 stage 2s on discharge, I'm going to skip that next question that says, of these stage 2s, how many were present upon the start of care? So here's an example. At discharge in A1, enter the number of stage 2 pressure ulcers that are observed at discharge. If no stage 2 pressure ulcers are observed, enter 0 in A1 and then skip out of A2. And again, if you're doing this on a computer, it's doing it for you, so you're not even going to have to think about it. If at least one stage 2 pressure ulcer is observed and reported in A1, enter in A2 the number of these stage 2 pressure ulcers that were observed at the same stage at the most recent start of care or resumption of care. So that, I know it's kind of like beating a dead horse, but it's an important concept to have. And then this just gives you the screenshot of looking at the discharge version. So the A1 is how many were present upon, how many of the wounds do you have now in whatever stage? So the first question there, A1, is stage 2. If I had 1 there, then the next question is, of these, how many were present on the start of care or resumption of care? So when you go through and answer these questions, think of them in that order. And then this is just a continuation of screenshots looking at unstageable due to non-removable dressing, slough or eschar, and deep tissue injuries. Again, remembering that last question that we removed the word suspected. So here's some additional coding guidance. I think it's important, the pressure ulcer definitions. Stage 2 pressure ulcers are characterized by the partial thickness loss of dermis, presenting as a shallow open ulcer with red-pink wound bed without slough. May also present as an intact or open or ruptured blister. Again, anyone who's heard me speak on this, I've said it again and again, between stage 2 and 3, that's where a lot of your clinical staff will have issues. So if they're describing a wound that has yellow slough on it, and they're coding it as a 2, can it be a 2? No, it's a 3. So it's just an important piece. So that's, if you're describing and you're doing some of these scenarios with your staff, it's important to make sure they understand what they're looking at. Stage 3 pressure ulcers are characterized by full thickness tissue loss. Subcutaneous fat may be visible, but bone, tendon, or muscle are not exposed. Slough may be present, but does not obscure the depth of the tissue loss. May include undermining and tunneling. So you can have a stage 3, and it could have some slough in it, but if it's a larger wound and you can really see the wound bed, then you need to be able to, then you can code that as a 3. But if there's too much slough or eschar that you can't really see down to the wound bed, you wouldn't code it as a stage 3, that you would say it's unstageable due to slough or eschar. And then a stage 4 pressure ulcer is characterized by full thickness tissue, loss of exposed bone, tendon, or muscle. Slough or eschar may be present on some or parts of the wound bed, but it often includes undermining and tunneling. But if you're looking at a wound, let's say it's 3/4 covered with slough or eschar, but you can see bone or tendon, what are you going to code that one as? Sage it as a 4, right? Because you can see the bone and the tendon. So it is at that point, by definition, coded as a 4. It also should note that a previously closed stage 3 pressure ulcer that's currently open again should be reported as a stage 3 pressure ulcer, unless it's gotten worse, where now you can see bone or whatnot. And a previously closed stage 4 pressure ulcer that is currently open again should be reported as a stage 4 pressure ulcer. So we're going to go into that. So the fact of the matter is, sometimes what happens is the skin closes over, the wound hasn't really healed. Okay, it's closed, but it hasn't healed. And in that exact area, if it opens back up again, it's still stage 4 or stage 3, whatever it was previously. So, so getting into that idea of healed versus unhealed ulcers or injury can be referred to whether the ulcer is closed versus open. So there's a couple of key concepts here. One thing is we don't reverse stage. And so that's another concept to make sure that we're clear with our staff when we're educating, because when someone comes to you, you may look at and assess the wound bed, and it may be, maybe they had been in another setting for an extended period of time. And what you're seeing is maybe what looks like a stage 3 or even a stage 2. But in fact, that wound maybe started off as a stage 4 or stage 3. and it will be a stage 3 until it's healed. So it's going to be really, we're going to probably getting ahead of myself in my slides, I know I am, that we got to go back through and look at the history and documentation from the previous setting. However, stage 1 pressure injuries or deep tissue injuries, although closed, intact skin, would not be considered healed. So the skin is intact, all right, especially if it's that maroon color and whatnot, that there's an injury going on underneath that. It still would be a deep tissue injury as described by our assessment. And a stage 1, that persistent redness that is non-blanchable and doesn't go away, is still a stage 1 pressure ulcer, right? Even though the skin is intact. And then unstageable pressure ulcers or injury, whether covered with non-removable dressings or devices, or eschar or slough, would not be considered healed because we don't know what's underneath that. All right. We're going to go through a bunch of examples here. So this is an important point if someone is coming to you with an injury of some sort, a pressure ulcer injury. You want to take as much effort as you can, that they make every effort to contact the previous provider, including the patient's physician, to determine the highest numerical stage of the pressure ulcer. So you can do this via, looking at transfer documents that came in. It could be that you actually spoke to someone and they verbally told you what the stage was at its greatest numerical stage, and you want to make sure that then you capture that, because that is what that pressure ulcer is until it's closed and healed. So unstageable pressure ulcers, so these are pressure ulcers that have eschar, tan, black, or brown, or slough, which is that yellow, tan, gray, green, or brownish kind of sticky looking tissue. Present, such as the anatomical depth of the soft tissue damage cannot be visualized in the wound bed and should be classified as unstageable. So if we can't get to the wound bed and we're really not sure what we're looking at, and we have all this slough and or eschar, then we need to code that as unstageable. And then if the wound bed is only partially covered by eschar or slough and the anatomical depth of the tissue damage can be visualized, then numerically stage the ulcer and do not code it as unstageable. So again, going back to what we already talked about, if you see the bone, you see the tendon, it's a stage 4. If it's somewhere partially covered with slough or eschar, the wound, but you can see the base and you're comfortable in staging, go ahead and then code that as whatever stage it is, 3 or greater. So at discharge, any numerically stageable pressure ulcer injury observed at the start of care or resumption of care that is unstageable due to slough and or eschar at discharge should be considered new and not coded as present at the most recent start of care or resumption of care. So this is a subtlety and a change in how we're looking at these. So if I had a stage 3 pressure ulcer or injury at the start of care or resumption of care, and then at discharge I go to looking at that same wound and it's covered with slough and eschar, so now it's unstageable. We're going to code it as that, right? Because we don't know what else is underneath that, and that wound is now considered new and not coded as present on the most recent start of care or resumption of care. Hopefully that's clear to everyone here. Does everyone understand that? Yeah? No? Okay, so let's spend a moment on that. So, okay. So I come in, I do my start of care, I do my skin assessment, and the patient has a stage 3 pressure ulcer on their coccyx. I go ahead and I treat that. I'm doing all the other care that I'm doing for that person. And now they're getting ready for discharge. And let's say you're going to discharge from service and they're moving to another state to be closer to their daughter or their son or loved one. And you go in and you're doing your assessment. And on discharge now, this stage 3 is now covered in slough or eschar. Probably was progressing that way and got covered, and you probably were dealing with it, I'm assuming. So now, when we go through the coding scenario, and I'm going to go through a couple of those, you would say that on admission, they had a stage 3 on their coccyx, right? On discharge, do they have any stage 3s? No, they have 0, right? We'll skip the next question. Now, when we get down to the unstageable due to eschar, slough or eschar, it's going to say, on the start of care, resumption of care, did we have any of those? No, we had 0. What do we have now on discharge? We have 1, right? And of those 1, the next question is, how many were present upon admission? 0, because I didn't have any when I started admission. Okay, and that's considered now new or worsened. Okay, not worsened, it's new. And again, we're going to go through examples of these, so I think you'll, by the time, we've put in I'm almost done with my basic slides. The rest are all going to be coding scenarios, and I think that's the greatest value, is to walk through the rationale on how we code these various areas. This is, I think that will help you to clarify any questions. So pressure ulcer injuries that are known to be present but are unstageable due to non-removable dressings or devices should be reported at M1311 D1, right? That's another opportunity there. So examples of non-removable dressings or devices include a dressing that is not to be removed per a physician order, okay, a practitioner's order, such as those used in maybe a negative pressure wound therapy, an orthopedic device, or a cast. There's a, you know, we can't remove it, and or it could be a primary surgical dressing that the doc says, you know, can't be removed. So in this particular area, we need to know that there's something under there, though, right? So known refers to when documentation is available that states a pressure ulcer / injury exists under the non-removable dressing or device. So we would need to have this information transferred to us that said there is this ulcer or this injury underneath this device. Otherwise, if just because they have a cast or they have some sort of a splint that we can't remove, we wouldn't code this as saying they had a pressure ulcer with a non-removable dressing or device. Does that make sense to people? So they have to come to you knowing that there's something underneath it. But what we're saying is we're acknowledging there's something underneath that because that previous setting told us, but we haven't laid our own eyes on it. So we don't know what it is. We only know what they told us it was. Okay. And again, you can get that from the medical record. It could be from verbally communicated to you. So here we have on discharge assessment, if an unknown pressure ulcer or injury is discovered upon removal of a non-removable dressing or device, that pressure ulcer injury should be considered new and not be coded as present on the most recent start of care or resumption of care. So that's exactly what I just talked about. If someone comes in with a cast or a splint that you can't remove, there's no documentation, no one's told you there's anything underneath it, now it gets removed, and then there's an injury underneath that related to pressure, then it's going to be considered new. Does that make sense to everyone? Yes? No? Maybe? Yes. Okay. So two different scenarios, and they're subtle, but they're important. One is we have the dressing, device, or whatever that can't be removed, and we know there's something underneath it. So we can go ahead and code that. We know there's a pressure injury underneath that. We haven't looked at it ourselves. The second scenario is someone comes in with a device, a cast, a dressing, something that we can't remove. And when it's removed, we didn't know there's anything underneath it. And then we find an injury underneath it. Does that make sense? Okay, good. So let's talk about deep tissue injuries. Deep tissue injury with intact skin at the start of care or resumption of care that becomes stageable is considered present at the most recent start of care or resumption of care at the stage at which it was first became numerically stageable. So again, this is another scenario. We have this deep purpley red deep tissue injury, let's say on a heel. So that's what we're going to call it, right? A deep tissue injury on the start of care. Now, it's 3 weeks in to caring for that patient, and now it declares itself. Usually declares itself sooner, but let's say it takes that long. And now you're looking and you realize it's stage 3. Now I can stage it. That injury then, once it becomes numerically stageable, it is considered present upon admission. Does that make sense to everyone? These are subtleties. Okay, we had a deep tissue injury. Now with a deep tissue injury, we don't know what stage it's finally going to land at, right? Especially heels, there are really classic ones. Has anyone taken care of someone who had a deep tissue injury and then it just covered with eschar? Okay, and if you take care of that patient for long enough, finally when that eschar flakes away and whatever, you have intact skin underneath. Has that ever happened to anyone? Okay. In that way, we never declared it. We were never able to stage that one. But that's what can happen. But often what happens is these injuries open up and then we get to assess them and understand what stage they are. So let's talk about surgical interventions. So any type of flap procedure performed to surgically replace a pressure ulcer is reported as a surgical wound until healed. It should not be reported as a pressure ulcer at M1311. So if someone had a large ulcer, they go in, they have surgery, they have a flap procedure done, that wound now will not be coded as a pressure ulcer. It's now coded as a surgical wound. A pressure ulcer treated with any type of graft is no longer reported as a pressure ulcer or injury until healed. It should be reported as a surgical wound. So now we have the graft and we have a flap. In both situations, what was a pressure ulcer now becomes a surgical wound. The third scenario here is a pressure ulcer that has been surgically debrided, remains a pressure ulcer, and should not be reported as a surgical wound at M1340. So one is they're, trying to resolve the pressure ulcer with the flap or the skin graft. The last one is we're just getting rid of devitalized tissue. All right, so it continues to be a pressure ulcer. So here's another point that is an important point, and again, another opportunity to educate your staff is around mucosal ulcers. So mucosal pressure ulcers are not staged using the skin pressure ulcer / injury staging system because anatomical tissue comparisons cannot be made. Important point. And we need to make sure that our staff understand that. It's amazing, every open wound on someone's body, there are some nurses out there that want to stage it, right? It could be a peripheral vascular ulcer, chronic venous ulcer, it could be anything else. They want to stage it. There needs to be able to remove pressure. Pressure needs to be part of the component for it to be considered a pressure ulcer. It's amazing, people want to, every skin tear, they want to stage everything. So we need to make sure that they are putting a little bit of blinders on. This is related to pressure. Therefore, mucosal ulcers, those related to NG tubes or nasogastric tubes, oxygen tubing, endotracheal tubes, urinary catheter, mucosal ulcers in the oral cavity should not be coded on the OASIS. And so, as far as related to pressure ulcers. And this is an important point, and I have to say that I was talking to someone actually from the hospital setting and where the hospitals report out, and they were talking about mucosal injuries. And there's a struggle even there that staff want to code mucosal injuries as pressure injuries, not understanding the difference in the anatomical presentation. So this is a good teaching point. Make sure that you can come up with some scenarios around this. So this is, I think, a good area when you go back and you're looking at your action planning. These are the types of things that where I've highlighted in some of the slides would be great opportunities to make sure that you're confident that your staff, whoever's going out and encoding this on the OASIS, have the knowledge. All right, we're going to go into some practice scenarios. So what I'd like you to do, if you are here in the room, if you can take out your coding scenario sheet. It starts with section J, go a couple of pages in, and then we get to M1311 practice, and we're going to start with scenario 1. For those of you watching live stream, you have the same access to this. And what I would ask you to do is think about the coding and how I did this for myself, and I actually went through all the coding scenarios this morning again. and just read the scenario and quickly coded it. And then you could do that yourself. It only takes a moment. And as we go through them, we're going to use, for the first couple of scenarios, we're going to use, I think, our Slido. So that was my first opportunity to do that. The nice thing about this also with these sheets is it gives you this scenario, because I'm going to move the slide, the scenarios on the top of each one of these sheets. So it says scenario 1. All right. So here we have scenario 1. A patient is admitted to the home health with a stage 3 pressure ulcer on her coccyx, and she has no other pressure ulcers are present. I made it a she. We're going to assume this person's a she. At discharge, it's entirely covered, this wound or area is entirely covered with eschar, and the wound bed cannot be assessed. No additional pressure ulcers arise during the episode. The patient is discharged from the home health services with an unstageable pressure ulcer due to slough and eschar. So let's go through. All right. So how would you code M1311 on the start of care assessment? And this is a Slido, so if you can go ahead and code this. So the choices are A, M1311A, stage 2 equals 1. Selection B, 1311B1, stage 3 equals 1. C would be M1311C1, is stage 4 equals 1. Or M1311E, 1, unstageable, slough, or eschar equals 1. All right, so we're getting there. How about 78 people who have answered? Okay, let's see what the answers are. And most people got it correct. It's a B, because this is looking at the start of care. So this patient came in with a stage 3 on their coccyx, right? So 1 stage 3 would be coded. Very good. So now, same patient. How would you code M1311 on the discharge assessment? So this is the discharge assessment. So M1311A1, stage 2, 1. In M1311B1, the stage 3 equals 1, or stage 4 equals 1, which is answer C, or D, unstageable, or slough, or eschar equals a 1. And you guys, let's see what the answer is. And everyone got this one correct, unstageable, slough, or eschar. So the follow-on question to this, and I don't think we have this in the, oh yeah, we do. So then the next question, was this unstageable pressure ulcer due to slough or eschar present at the start of care? So the answers are A, yes, coding 1, B, no, 0, or C, skip. We're getting a lot of people answering. And the answer is no, right? Because we came in with a stage 3, and now we have eschar or slough covering it. All right. And if you were educating your staff, I would have them go through and answer all of the questions. So here you would see, you know, stage 2 pressure ulcer, start of care, this patient didn't have any. At discharge, they didn't have any. So then we skip the next question, that A2 question. Next one, stage 3 pressure ulcers, they had 1 at admission, or start of care, and then at discharge, they had 0, so then we skip. And then we don't have any stage 4s, so that's 0, 0. And then unstageable due to non-removable dressing is 0, 0. And then we get into E1, which is the number of unstageable pressure ulcers due to slough or eschar. We had 0 on admission. We have 1 at discharge, or start of care. We had 0. Discharge, we have 1. And then that big question is how many of these that are present were there at the start of care, and we have 0. All right. So the rationale here, at admission, the patient had a stage 3 on her coccyx, so that was 1, which we understood that to be. And then at discharge, the stage 3 went to unstageable. And so we would code E1 as 1 and E2 as 0. All right, practice scenario 2. So if you just flip your paper, you have the next scenario. So we're going to go through these pretty quickly. So a patient's admitted to home with a referral documentation indicating the presence of a stage 3 sacral pressure ulcer. So on the admission paperwork or discharge paperwork from the previous setting saying they have a stage 3 ulcer. This ulcer is covered with a non-removable dressing and therefore is unstageable at start of care. There's no other pressure ulcers or injuries at present. An order is obtained to change the dressing on day 4 of the quality episode, and the assessment reveals a stage 3 pressure ulcer. On day 9 of the quality episode, the pressure ulcer is covered with eschar and is assessed as unstageable. The eschar-covered ulcer is unchanged at the time of discharge, and no other pressure ulcers have developed during the quality episode. A little bit more complex, so let's think this one through. Again, the scenario is written on the top of your paper here as a reference. So let's think about this. So how would you code M1311? So is it M1311B1, stage 3-1? Or D1, unstageable, non-removable dressing or device equals a 1? Or unstageable due to slough or eschar? Or F1, unstageable deep tissue injury? Okay. So we have some people, we have about 76% saying it's unstageable, non-removable dressing. 1 says slough or eschar, or 2% say that, and 21% say stage 3. So let's look at the answer to this one. And the answer is, it is actually B, unstageable non-removable dressing, because remember, the patient was admitted to you with a non-removable dressing. They told you it was a stage 3, right, from the previous setting. But when they came to you, you couldn't actually visualize it because they had a non-removable dressing. But you knew there was an ulcer underneath there. So this is where you would code this as unstageable, non-removable dressing at admission, or start of care, sorry. Is that, everyone got that one down? Yeah? Okay. So now let's look at the discharge assessment. So here, for the discharge, how would you code M1311B1? Is it a stage 3 equals a 1? Is it M1311D1, unstageable, non-removable dressing or device equals a 1? Or 1311E1, unstageable slough or eschar equals a 1? And then 1311F1, unstageable due to deep tissue injury. Right. So we have most people saying that this is E1, unstageable slough or eschar, and we have 4% saying it's a stage 3. So let's look at the answer. And you're correct, the majority of you are correct, as the unstageable slough or eschar. Now, the next question is, was this unstageable pressure ulcer due to slough or eschar present at the start of care? Yes, no, or skip? I'll just give it a moment. Okay, and the majority say no. And let's see the answer. And the answer is no. And in fact, the eschar, we knew they had a stage 3, right? But from the previous setting, but we had that non-removable dressing, then we remove it and it develops by the time of discharge, slough and eschar. So now it's coded as no, it was not present upon admission. Is that any questions on that one? Everyone seem pretty comfortable? And we'll go through, and this is exactly how this would, if you were looking and encoding this, and if you were using your sheet, the first sets of questions would all be zeros, so stage 2, stage 3, stage 4. And then on admission, we have that unstageable due to non-removable dressing. Discharge, we have 0. And then if we continue on, oh, I'm sorry. So the number of unstageable pressure ulcers due to slough or eschar, that should have been on admission it was 0, on discharge it's 1, and then that follow-up question is how many were present upon the start of care, and we have 0. And here we have the rationale, and so you can certainly use this information when you're going to teach. And I think I went through this already, so I won't spend a lot of time on it. And then it goes through extensively the rationale on this, and we explained that. Do you want to go back to the rationale to some people? Yes? Okay. All right. So let's go through the rationale. So the documentation that accompanied the patient at the start of care identified the pressure injury located beneath the non-removable dressing. Remember, we didn't do eyes on, but we know there's an ulcer underneath it, and they told us it was a stage 3. The pressure ulcer injuries that were known to be present but are unstageable due to non-removable dressing or device should be reported M1311 D1 as unstageable, right? Because we're not able to put our eyes on it, we know there's an ulcer. Known refers to when there's documentation is available and states that the pressure ulcer or injury exists under that non-removable dressing. So we're all clear there, right? We know that there's an injury, an ulcer underneath there. We have this dressing. They told it was a stage 3, but we haven't done eyes on. So the next portion of this is on day 4, the dressing is changed and a stage 3 pressure ulcer is identified. So now we have eyes on it, right? They told us it was a 3. We take the dressing off, we know it's a stage 3. At the time of discharge, the pressure ulcer is covered now with eschar and cannot be numerically staged. So non-removable dressing, we know there's an ulcer stage 3 underneath there, supposedly from the site beforehand. Day 4, we take the dressing off, we clean it and examine it, and we code it as a stage 3. And then at discharge, we're again assessing the patient. And that same exact wound has slough and eschar over it, and we can't see the base of the wound, so it's non-stageable due to that. So E1311E, unstageable pressure ulcer due to slough or eschar, is coded as 1, because that's what we're seeing at discharge. And then we ask the question of those, the unstageable due to slough and eschar, how many were present upon the start of care, and we have 0. All right? Is that clear? I'm not hearing a lot of positives. It's an important piece, though, so I want to make sure that you get it. So if you step by step, again, they came to you with a non-removable dressing and you have a known injury underneath it, step 1, and you encode that in the start of care. 4 days later, you've got an order, you can take that dressing off, you clean it, you look at it, you confirm for you, it's still stage 3, okay? So now it's the first time that I'm observing I'm able to encode it. It's present upon admission as a stage 3. At discharge, I look and I have a slough and eschar. And so now we have to code that as covered as slough and eschar because I don't know what's underneath that. By the time that slough and eschar comes off, they'll be in another setting, but that could be cleaned off and that could be a stage 4. We don't know that until that's cleared off and we can see the base of that wound. All right, let's try another scenario. So this is practice scenario 3. So here we have, all right, the RN assesses Mr. J's skin at start of care and identifies a deep tissue injury with intact skin on his left heel. This DTI remains unchanged until the RN skin assessment 10 days later, which reveals open skin presenting as a stage 3 pressure ulcer. The pressure ulcer does not change for the remainder of the episode. And then at discharge, skin assessment, the ulcer remains a stage 3. There are no other pressure ulcers or injuries at the start of care assessment during the quality episode or at discharge. So now let's look at these. So how would we code this? This is at the start of care. So do we have a stage 3 equals 1, unstageable non-removable dressing equals 1, unstageable slough or eschar equals 1, or unstageable deep tissue injury? Okay, and the majority of people got this correct, saying it's a deep tissue injury, because that's exactly what they found on the start of care. And in fact, that is the answer. Because Hasn't declared itself yet. All right. So now we are at the discharge assessment. So they came in with a deep tissue injury, and then 10 days in, it declared itself as a stage 3. How would you code M1311 on the start of care, the discharge assessment? Would it be stage 3 equals 1, non-removable dressing, a device equals 1, unstageable due to slough or eschar equals 1, or a deep tissue injury? Okay. And we have almost everyone having this coded as A, M1311B1, stage 3. Let's see what the answer is. And in fact, yes, it is a stage 3. So remember, even though they came in with the DTI, once the first time we stage it, it's now declared itself. The first time we can stage it, and then because it didn't change, it's considered present upon admission. The first opportunity to stage it. Now, if that same wound got covered with slough or eschar, okay, it wouldn't be a stage 3 anymore, right? It would be unstageable due to slough or eschar. Or if it had decreased in or increased in stage to a stage 4, it would not be considered present on admission. Again, subtle points, but these are really important to make sure when you're educating. And then the next question, was this pressure ulcer present at the start of care? Yes, no, or skip? So let's see what you guys say. I'm going to let this play out for a moment because I think there's some confusion here. Okay, so we have 67% said yes and about 30% saying no. So let's look at the answer here. And the answer is yes. Now it's important though, 30% of you got this wrong. So the issue is here, they came in with a deep tissue injury. I feel like I'm beating a dead horse here, but I'm sorry, but this is important and some of you are not getting it. That deep tissue injury, sorry, my friend Lisa here is like, cut some of your scenarios, and I will. So deep tissue injury, and then you have, it declares itself 10 days later, right? Now it's staged as a stage 3. Remember, the first time we can stage it, then that becomes considered present upon admission. And because it didn't change at all, on discharge, it's considered present upon admission. All right. So I'm not going to spend a lot of time. These are just the coding, this just how you would code it. And I just went through the rationale with you. And so this goes through the coding assessment. All right, let's go to coding assessment 4. I have about 9 minutes left. So in coding assessment 4, the RN completes a skin assessment during the start of care visit for Mrs. K and identifies a right hip deep tissue injury. This deep tissue injury is first numerically staged 10 days later as a stage 3 pressure ulcer and increases in numerical stage 5 days after that to a stage 4. The pressure ulcer remains a stage 4 at discharge. So this is exactly the scenario I just talked about, but let's walk through it quickly. So how would you code M1311 on the start of care assessment? Okay. Is it a stage 3, a stage 4, unstageable, slough or eschar, or unstageable deep tissue injury? Okay, and the majority of you said unstageable. Let's see what the answer is. And in fact, it is unstageable, remember? So the scenario is that the patient came into your start of care and they had a deep tissue injury on the right hip. So that's all you care about for start of care, right? Deep tissue injury. So the next question is, how would you code this at discharge? So remember, here we're looking at, is it a stage 3, a stage 4, unstageable due to slough or eschar, or unstageable due to deep tissue injury? Okay. And the majority of you have said stage 4, and let's see what the answer is. And in fact, it's a stage 4. Some of you put a stage 3. And it's true that the first time it declared itself, right after once we noticed it as a deep tissue injury, It evolved, okay, and what we call this declaring itself, it was a stage 3. But the caveat is it continued to worsen and got to a stage 4 during the time that you were caring for that patient. So on discharge, it in fact is now a stage 4 and not present upon admission. If it had stayed to stage 3, the stage 3 would have been considered present upon admission. But because it got worse, it became not present upon admission. Subtle points, but important. Was the pressure ulcer present at the start of care? Yes, no, or skip? And so let's see if people answer this. Okay. So we have 35% of you say it was yes, it was present upon admission, and 66 say no. And let's see what the answer is. And again, this is no. And the reason for that is deep tissue when they came in, during the time that you cared for them, it got to, the first time it told you could assess it and stage it, it was a 3. And at discharge, it's a 4. So if it had stayed a 3, it would have been considered present upon admission. But because it got worse, it's considered not present upon admission. So there's a fair amount of confusion here, so I'm a little concerned about that. I'm not sure how else to say this information except for to really go through and have you understand the rationale. So these are the coding scenarios. Let me just get to the rationale. So the deep tissue injury with intact skin observed on the start of care assessment and then first became numerically staged as a stage 3. The stage 3 pressure ulcer increased in numeric stage to a stage 4 at the discharge assessment. Therefore, a stage 4 ulcer at discharge is considered new and not coded as present on the most recent start of care or resumption of care. Again, if it had stayed a stage 3, it would have been considered present at the start of care because it, in fact, was the first time that you could stage that. All right, let's quickly go through. I think we'll get one more scenario in. Scenario 5. And then in scenario 5, the RN assesses Mrs. L's skin during the assessment time frame for start of care and identifies a deep tissue injury with intact skin on the right heel. This deep tissue injury first becomes numerically stageable at the 3rd home visit as a stage 3 pressure ulcer. At the discharge skin assessment, this pressure ulcer is unstageable due to slough or eschar. Now, we've talked a lot about these, so let's see how we do now. How would you code M1311 at the start of care assessment? A stage 3, a stage 4, unstageable due to slough or eschar, or unstageable due to deep tissue injury? Okay, and let's look at the answer. And the answer is unstageable deep tissue injury, because in fact that's what they said, right? On the start of care, the patient had a right heel that was unstageable due to a deep tissue injury. Now we go to discharge. How are we going to code this assessment at discharge? A stage 3, a stage 4, unstageable due to slough or eschar, or unstageable due to deep tissue injury. And the answer is unstageable due to slough or eschar. So again, in this scenario, they came in with a deep tissue injury. It declared itself as a stage 3, and now the pressure ulcer remains. This pressure ulcer gets covered with slough or eschar, and so is unstageable due to that. So the same question we'd ask here, was the pressure ulcer injury present on the start of care? Yes, no, or skip. Okay, let's look at the answer. And in fact, the answer is no. And again, that reasoning is deep tissue injury became a 3, and now it has slough and eschar. Now, thing to remember here is there's a slight different change, right? Where it used to be different with new or worsened, and if it had just gone unstageable for the way that we used to calculate the measure, it wasn't considered new or worsened. The way that we're looking at it now, at least for this coding methodology, it is considered there and in fact worsened, all right, with the slough and the eschar. All right. So these are actually how you would code this scenario. And again, these are all going to be put out there with the answers so that you can use these when you do training. All right. So I have a variety of more scenarios, and I'm not going to have time to go through them, so I'm going to just go through these coding scenarios. But just know that they're there. We put in a whole bunch of different coding scenarios for you to use for training. And I would ask you to go through those, and I'll be here today if you have any questions as you're thinking about those, maybe over lunch, because that's exactly what you want to do over lunch, is discuss wounds. Yeah, I'm here to answer any questions. Okay. So in summary, changes in skin integrity post-acute care, the pressure ulcer injury is a cross-setting quality measure implemented to meet the requirements of the IMPACT Act. So we're doing this across all of the post-acute healthcare settings. It replaces the current pressure ulcer measure, % of residents or patients with a pressure ulcer that are new or worsened. And the quality measure includes new or worsened unstageable pressure ulcers, including deep tissue injuries in the measure numerator. And the measure calculation has been amended to include M1311 items instead of M1313 items to reduce redundancies. And the revisions are informed by the National Pressure Ulcer Advisory Panel guidelines. What I would encourage you to do, and I know I'm between you and lunch, but what I would encourage you to do is take your action item packet. And this is a section that I think is a real opportunity to educate staff on. And the fact that we're sitting in this room and online, that there's people struggling with these section, go ahead and really just do all these scenarios and practice with your staff. I think that should be one of your action items when you go, when you leave here. This is what's going to make you have accurate assessments, and that's what we're looking for, right? Accurate assessments, and this is going into a quality reported measure, so you want to make sure that it's not garbage in and garbage out, that we have and we understand how to encode these. Thank you very much, and I'm sorry for going a little bit over, and I'll be around if you have any questions. Bridget.